Good evening, doctors. My name is Anupam, and on the behalf of FDC and MedTalks, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra Season 3. Today's topic is very interesting topic, diabetes food. Today's session is brought to you by your zero calorie electrolyte drink Enerza Zero. Now, before moving forward, I would like to announce last week quiz winners. Dr. Devraj Bhai Dholaria from Surat, Dr. Bharat Praveen Mitakota from Surat, Dr. Gangadhar Rath from Bhubaneswar, Dr. Jitendra Kumar Dayalal Shah from Bayad, Gujarat, Dr. Ashwini Kumar from Kanpur, Dr. Ashutosh Das from Tamluk, Dr. Girish Jesota from Mumbai, Dr. Surjit Kalsi from Noida, Dr. Anjana Bhargava from New Delhi, Dr. Manju Vasudev from Mumbai, Dr. Shashi Khare from Bhopal, Dr. Kaval Saluja from Mumbai, Dr. Ravi Bhatt from Sursi, Dr. Satish Kumar Jain from Bangalore, Dr. Anand Purande from Mumbai, Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Neeta Kochar from Nagpur, Dr. Sanjeev Puri from Hoshiarpur, Dr. Vilas Sunamane from Ashiti, and Dr. M.R. Chipa from Barmer. So I will like to thank all the doctors to take part in our quiz. Now, to enlighten us regarding today's topic, I would like to welcome Dr. Sanjay Kalra, Chairperson, Education Working Groups, International Society of Endocrinology, and past President, South Asian Federation of Endocrine Society. Over to you, sir.
Thank you, Mr. Ankur, and good evening, everyone who is logged in with us today. It's always fun being part of Diabetes Essentials, and we welcome everyone, including Dr. AR and Dr. Anup Shukla, who joined us. Every month, we have an expert to speak to us about the difficult parts of diabetes, and today we have our all-time favorite, Dr. Suneet Verma. Dr. Suneet Verma has helped us understand diabetic fever and we remember the various causes of fever that Dr. Suneet causes sometimes, in his OPD, in his ward, in his neighborhood. So he has told us about diabetic fever. He's also helped us understand dengue fever, acute viral illness, acute febrile illness. So thank you, Dr. Suneet, for all that you've done for Diabetes Essentials.
Thank you, sir.
Today we continue with another aspect of diabetes, which is related to infection. And before I forget, for all people who have joined us, Dr. Suneet Verma is a consultant physician and diabetologist at Alchemist Hospital in Panchkula in Haryana and at Spurs Clinic in Zirakpur in Punjab. Truly national figure. His forte is obesity management and behavioral therapy of obesity. So, Dr. Suneet, our topic for today is diabetic foot. Uh, Now, the foot is such a small part of the entire body. Why is it so important? Why does it get a separate mention everywhere in diabetes textbooks?
Thank you, sir. Thank you for inviting me. And uh, diabetic foot, as you rightly said, sir, why not diabetic hand? Why not diabetic head? Why not diabetic heart? So every organ is important. Then why diabetic foot per se? Problem is like this. We call the complications of diabetes, diabetics, neuropathy, nephropathy, retinopathy. First of all, let's see why do we treat diabetes? मेरा ब्लड शुगर बढ़ा हुआ है, मुझे उसे ठीक करना ही क्यों है? मेरा क्या बिगाड़ रहा है? जब तक मैं उसकी वैल्यू ना चेक करूँ, मुझे उसे ठीक करने की ज़रूरत क्या है? सो द थिंग्स आर लाइक टू प्रिवेंट दिस कॉम्प्लिकेशन जिसका मैंने अभी नाम लिया माइक्रोवास्कुलर एंड मैक्रोवास्कुलर कॉम्प्लिकेशंस। इन सब चीज़ों में जो बहुत डेबिलिटेटिंग है, सारी खराब है, वो है न्यूरोपैथी, वो है एथेरोस्क्लेरोटिक इलनेस और वो सबसे पहले पाँव से शुरू होती है। अब पाँव से शुरू होती हैं और उस पाँव पे यदि कोई घाव बन जाए, ये हमें सबको पता है, यदि वो घाव बन गया, इफ यू हैव अ अल्सर इन फुट, especially in a diabetic, uncontrolled diabetes, this will not heal easily. So to emphasize, to actually prevent these kind of complications, we have actually a very special emphasis on foot care. So we do take care of foot a lot. So we need to take care of our foot a lot. So there is a special mention of foot care in diabetes.
Thank you, sir. And we also welcome Dr. Gauri Shankar from Karnataka and Dr. Manu Sharma from Delhi. So, and Muhammad Taj Sahib also. Hello. So, Dr. Suneet, the floor is yours. Would you like to take us through the pathophysiology, the clinical presentation, and then perhaps the management of diabetic foot so that we can make it simple for everyone to understand?
Sure, sir. Let me start with the slides, sir. FDC team, please do the needful. Thank you. Thank you so much. So, Things are diabetic foot. Diabetic foot, as just I just mentioned, this is the most dreaded complication of diabetes. Why? If somebody is having a ulcer on foot and that is not paining, it's not painful. He is not getting any neurons are not getting any information, but it's oozing. And whenever he starts or he or she starts dealing with this ulcer or some lesion in the foot, by all means, he has or she has used topical, some sort of antibiotics of his own knowledge, there is no healing. And the patient always gets very worried. Why my foot ulcer is not healing? Is it cancerous? Is it something else? I'm not able to wear my footwear. I'm not able to walk. It's swollen now. It's oozing allwhere. My bone is exposed. Doctor has advised that I may need to get my foot amputated. So this is like quite worrisome kind of problem. A patient of diabetes, if he develops diabetic foot, like it's bothering, it's a serious and very difficult to handle kind of situation. So why a patient actually develops diabetic foot? Some fault is ours. We as a treating physicians, as a treating diabetologist, we probably are not able to educate our people or our patients enough, or not able to examine their foot enough in every visit. So, if they develop some initial signs so that they can prevent the development of florid diabetic foot ulcer. So, there is a definite gap in what we know, what we should tell our patients, and how should we practice in our diabetology so that people do not suffer from diabetic foot. So, what are the basic risk factor? Why there is a ulcer? Why there is ulcer is breach in continuity of skin. This is ulcer in simple language. So, we all know ulcers can be because of some neuronal problems in diabetes or maybe arterial problem in diabetes. So, PAD or peripheral arterial disease is common in diabetic patient. Why? Because in general, in an average, atherosclerotic illnesses are more common in diabetic patients. So, atherosclerotic illness they develops in coronaries, in a cerebral vasculature and peripheral arteries. In peripheral arteries, when almost 54% of ulcers, all ulcers are from a diabetic peripheral artery disease. So peripheral artery disease is an important aspect, is an important reason for vascular compromise. Why there is at all an ulcer formation in a diabetic patient? There is some problem with microvasculature. The vessels which splice the nerve or vessel which splice the skin or nerves of skin, they get some clotting. So there is a problem with vasculature, microvasculature. If there is a problem in the peripheral artery, peripheral limb artery, big arteries, there is some clot formation is there. This will lead to some ischemia in the ischemia distally. And if get unnoticed, a patient is having other risk factor like smoking, then the chances of this getting converted to gangrene remains high. If somebody has developed gangrene, be the dry gangrene, the peripheral artery cases, the chances of amputation, going for amputation, maybe a partial amputation, remains very high. Another reason is neuropathy. Neuropathy we divide into two types: somatic and autonomic. Somatic neuropathy. Somatic neuropathy can be motor, can be sensory. So in motor neuropathies, how a motor neuropathy can lead to development of ulcers. Motor neuropathies can lead to development of callus because of some atrophy or hypertrophy of particular small muscles. This will lead to undue pressure on some particular areas, and that will lead to callus formation. And callus formation is not that simple or is a casual in case of diabetic patients. Why? There is a definite pressure point, and that pressure point can develop a microhematoma under it due to constant pressure, and patient doesn't have any feeling mind, it is a neuropathy. They may have some sensory component also, so they do not develop any pain. So continuous pressure will lead to microhematoma formation under the callus and ultimately lead to ulceration. So that is a big problem. Second is sensory neuropathy. patient doesn't have a sensation of pain, temperature, vibration. They don't have sensations. So what if a patient is not having a sensation of hot and cold? They may get their feet burn with the heater in winters. They don't feel. They sleep with the heater on. They sit with the heater on, and putting their feet very close to the heating point. And in the morning or in afternoon, the 2 hours, they say this is totally burnt because they don't have any sensation of pain, of temperature. Same is if they have some nail in their shoes that keep on hurting them, but they don't feel it. One day they find a big ulcer is there. Vibration problems. If they have proprioceptive problems, they have recurrent falls that can again increases the chances of foot ulcers. So motor neuropathy or sensory neuropathy can lead to ulcer formation, as explained. Sometimes another neuropathy is autonomic neuropathy. What autonomic neuropathy does, this causes dryness of skin and crack formation. Ultimately, again increase the chances of ulcer formation. So neuropathy and peripheral artery disease per se individually can lead to ulcer formation. On top of it, usually these conditions coexist. So patient do have a peripheral artery disease and neuropathy simultaneously. So chances of getting an ulcer remains very high. On another problem, unique problem in Indians is like we are barefoot walkers, especially in religious places. Be it a very hot, very hot floor, or maybe some areas where the things are not even clear, in clean. We keep on walking barefoot. At our houses, we have a habit, especially in the south, barefoot walking. It's very common. Improper footwear. Either it's too small, it's a too tight, or it's a too large. Another factor is patient had some hints. They have callus formation in feet. They have small ulcer, but they keep on ignoring it because they don't know whether they should ignore it or give them some attention. They don't have education. We have failed them. We are not able to give them proper education regarding the care of their feet. Why we have not even able to give them education? Probably we are not aware of that we should educate our patients. So lack of education to healthcare providers, lack of foot protection services. We know this should be done, but where to go? Where to send patient? Do I need to manage? How do I manage? We don't have proper services. So all this can lead to increased chances of ulcer formation, and ultimately, if ulcer is not taken care of, this can lead to amputation. Another unique problem is charcot foot. This is osteoarthropathy, neuropathy, trauma, inflammation, everything. It's a big rocker bottom foot is there. It's a neurological problem, and profound neuropathy is there, and ultimately lead to osteoarthropathy. Multiple fractures starts with the midfoot disc joint and involves almost everywhere in the foot. This can be acute charcot or chronic charcot. This will lead to foot deformity and may lead to amputation. So, as Sir was asking in the beginning, why foot has been given so much of importance? Because this is so important. We don't know. Many of our colleagues are not aware of this importance. They don't give this much of importance to the foot care. Even if we give this much of foot care, due to some reasons, maybe rituals, patient keep on walking barefoot. They develop foot ulcer. They are not able to take care of because they need to stand, they need to walk. They are not able to offload. They develop ulcer. So another thing is, how do we diagnose? This is, we have seen why foot ulcer is there, how this foot ulcer develops. Now, how do we diagnose it? Can we diagnose? Yes. Can we do it by clinical examination? Do we have a specific test, something XYZ kind of test for this? Very basic kind of thing. Simple, look at a foot. A patient is coming to us. What ADA says, examine a foot every year of every patient who is coming to you. But if patient has neuropathy, examine every 4 months, every fourth month. But what we say in India, because diabetic foot, because of barefoot walking habit, because of poor foot care overall, we say examine foot on every visit. And what to examine? Look at the grossly, if the foot is showing any sort of ulcer, any sort of callus formation, feel for it. Then look for peripheral vessels, posterior tibial artery. Then is like dorsalis pedis can be seen. This can be spayed also. Then look for any sort of neuropathies. How do we check for neuropathies? We'll discuss. It's a simple thing. This can be done. Then look for any edema. A patient may have a coexisting renal failure. Patient may have a coexisting heart problem, heart failure. They can have edema also. And then look for any ulceration or gangrene. Look for any fungal infection in between the toes. Look for any cracks. Look for any deformed or ingrowing toenail. That is also very important. And this is not difficult. This is doable and takes hardly a minute. But we need to look for it. Then more specifically, look for vibration sense. This can be done with a tuning fork. 128 hertz low frequency tuning fork is important. That is to be applied on a bony prominences. And we need to find out if patient is able to feel vibrations when he feels, when it starts and when it stops. So examination and assessment is not difficult. And I tell you, there is no specific test to diagnose. There is no specific hi-fi test. There is nothing like you have to, the patient has to leave your clinical room to get his diabetic foot diagnosed. This is what we must know, how to see it, how to look for it, and we should have a willingness to look for it. We can check for like pain sensation, position sensation, vibration sensations. Vibration sensations we know, look at the bony points with a tuning fork. Peripheral neuropathy is like, one thing is known as monofilament test, 10G monofilament test. And this is so simple and easily doable test which can actually detect a very early cases of peripheral neuropathies. We just need to check with a monofilament, press it against the foot as shown at the 9 points, 10th point on the dorsum. So at 10 points, we need to check for any sensations, if they are able to feel it or not. More technical, if we see what is more technical or as a more quantitative, is biothiometer. So biothiometer is like, if we don't have a biothiometer, we can check it with a monofilament. That is easy, doable, cheap, and very effective. So we can diagnose by a simple basic clinical examination. We can look for neuropathy. We can check for peripheral arterial disease, PAD. Simply ask a history of claudication, maybe intermittent claudication, and claudication distance. After walking, how long he develops a pain in the calf muscles, in the calf area, and after how many minutes, or maybe 30 minutes, 40 minutes, 10 minutes, 5 minutes, his pain is relieved. And more technical test to check it is ankle brachial index. Ankle brachial index is a very important thing. We all know the pressure in the lower limb is practically, it should be more than what is there in our arms. So what is the ratio? Normal ankle brachial index ratio is ankle versus brachial blood pressure. What is normal ratio is 0.9 to 1. 1.1, 0.9 to 1.1. If it goes below 0.9, then this is definitely suggestive of some sort of occlusion in the peripheral artery. So pressure is not being conducted. So this is a marker of peripheral artery disease. And what is critical value for ABI? The critical value is less than 0.5. If somebody is having ABI less than 0.5, that means that he is having very critical stenosis and should be immediately referred to vascular surgeon for the needful. They should undergo CT angios if possible, or maybe and interventions, maybe stenting, maybe some surgeries. So this is how we check with the help of a Doppler, ankle brachial index, pressures in the ankle and then the brachial artery. then simple ankle divided by brachial. Prevention of diabetic foot. This is like what we have seen so far is neurological examination, then vascular examination, peripheral vascular examination. Very basic, doable kind of thing. Now, how do we prevent it? We have diagnosed that person is having some problem. He is having loss of proprioceptive sensations. He is having loss of vibration sensations, or maybe monofilament test is positive. His dorsalis pedis or maybe the posterior tibialis is not palpable. So how do we go with it? Confirm. If you are suspecting vascular disease, let's confirm with a simple arterial Doppler, which is again usually can be done in any ultrasound center. If we don't have, don't wait for it. We can still do many things. How do we prevent diabetic foot? The most important thing is we must know there is a diabetic foot. So examination. Ask for it, look for it, and diagnose it. Then if we have diagnosed, the foremost important thing is prevention. And how do we prevent it? Glycemic control. What is glycemic control? We all know the most important thing is always and always diabetes, blood sugar level should be, blood glucose level should be within normal limits. What is normal limit? Normal limits are, we all know, fasting blood sugar should be less than 130, but in a diabetic foot would like to be somewhere around 120, 110. Postprandial should be less than 180, as close to 150 as possible. That is a good control. HbA1c should be as close to 6.5, not 7. If patient is having profound age-related problem, some other problems, as close to 7 as possible. There should be good glycemic control. Then patient must be aware that this is a problem. This will lead to a hell lot of problems in future. So patient education is very important. Then comes the role of footwear. Footwear is extremely important. Why footwear is important? We must educate our patients that they must check. They must check their footwear once in every week at least. If they are not able to do, any younger person in their family should check it with their hands inside the foot in a footwear to check for any irregularities, any nail going through it, anything, any pebble inside. This looks like weird, but it's true. Patient can have a pebble inside, some छोटा सा पत्थर अंदर पड़ा है, वो पड़ा है 6 महीने से, उसको पता ही नहीं है, उनको फील नहीं होता, and that is leading to ulcer formation, and that is very important and is easily doable kind of thing. Then there are special footwear for diabetic foot for offloading. That is a separate topic as such. Then to cut short, when should we refer our patients? If we have diagnosed diabetic foot, when should we refer our patients? So referring a patient is very important. One thing is, if we find there is a critical cyanosis, patient is having gangrenous foot, then definitely we need to refer. Patient is having ankle brachial index less than 0.5, again definitely we need to refer. Patient is having involvement of bone in ulcer, we are suspecting osteomyelitis, we have to refer. Why refer? Because that will probably need IV antibiotics, that may lead comprehensive care under a podiatrist or maybe orthopedician or a general surgeon, along with physicians. He may or may not need this amputation. Offloading is very important. If patient is having a oozing ulcer, he will need some sort of debridement. Patient is showing some changes in ECG than in clinic. So mind it, PAD or peripheral arterial disease we are diagnosing is a hallmarker of CAD also. Look for coronary artery disease. That is also very important. So we need to refer them. And how do we refer them? Do we put in some antiseptic on it? No. Just clean it with the normal saline. Do a sterile dressing and send the patient. Urgency to be explained to the patient that this is urgent. Please don't wait for 1 month and you're good to go before seeing a specialist. What are the basic tips for taking care of foot uh, of the patient living with diabetes, we must tell our patient they should inspect their foot regularly. Look between the toes. Is there any fungal infection? Is there any cut? Look for cracks. Look at the heels. Use moisturizers daily. And they need to cut their nails straight. Don't cut it like curvy. Look for ingrowing toenail. If they is there, they need to consult immediately. Don't try to remove cones with this commercially available tapes. They have a salicylic acid, and salicylic acid ultimately lead to some ulcer over there. If they develop some careless, we can use, like, they need to soak their foot in hot water for 10 minutes, and then they can rub it in one direction with the pumice stone. That is one way of treating with the at home this kind of careless formation. Wear socks, cotton socks. That is also very important, not nylon kind of socks. Avoid walking barefoot. And if they need to go to temple and they need to walk barefoot, please choose a time when it's not very hot. The stone is not very hot on the floor. Just be careful about the things on the floor. And if they develop some ulcer, they need to really see a person who is expert in looking after the diabetic foot. As a healthcare provider, what we should know that we need to examine foot. That foot is extremely important part in the care of diabetes, in the care of humanity. If you find out something, if we can diagnose neuropathy early, we can prevent a formation of diabetic ulcer by educating our patient. And that will save him a lots and lots of money. We have a data from India, in South India. If a patient living with diabetes going to government setup where he is not supposed to pay any special fees, spends almost 5,000 rupee per year on extremely basic kind of medications, subsidized medications. But if he need per month, sorry, if he need to, if he develops diabetic foot, this expenses increases to 17,000 a month. So this much is the magnitude, or more than 3 times. And if they need to get themselves admitted because of this diabetic foot, so the expenses are like beyond control. And if they need to go for amputation, the trauma is horrible. So we really need to take care of our foot well. So what is the core tip? Diabetic foot can be prevented with our efforts, with patients' effort, with educations, our education and patients' education. We must know, we must tell, and we know when to refer our patients. Then we need to tell our patients the importance of foot care. Thank you. अभी इतना ही कहना चाह रहा था. Over to you, sir.
Thank you, Dr. Suneet. Thanks everyone for logging in today. We have questions as well. So perhaps we can have the slides again and we'll ask the questions. Next slide, please.
Yeah.
So
What is
we
the
have
primary
3 questions. Yeah, the first two Dr. Suneet will ask.
What is the primary cause of diabetic foot ulcers? Bacterial infection, poor blood circulation, trauma to the foot, or nerve damage? Should I repeat? What is the primary cause of diabetic foot ulcers? Bacterial infection, poor blood circulation, trauma to the foot, and nerve damage. Second question is, which of the following is a characteristic feature of neuropathic diabetic foot ulcer? Deep, well-defined edges. Second, elevated temperature around the wound. Third, decreased sensation in affected area. Fourth, increased blood flow to the wound site. I repeat, which of the following is a characteristic feature of neuropathic diabetic foot ulcer? Deep, well-defined edges, elevated temperature around the wound, decreased sensation in the affected area, increased blood flow to the wound site. Over to you, sir.
Thank you, Dr. Suneet. And the third question is, there is this beautiful Punjabi song. The singer says, "Je yaar ni banana goriye." So, fair girl, if you don't want to make me your friend, if you don't want to give me a place in your heart, Changer banale perdi. Uh, just put me on your foot, make me an anklet. So you have two questions, and it's up to you. Answer either of them. The first question is who's the singer, and the second is who sang this to whom. And the hint is you see somebody smiling in front of you. So okay, so two questions: who is the singer, and see the poetry that comes across. Je yaar ni banana goriye, chanjar banale pair di. Basically, what he's saying is the heart and the foot should be given equal attention, equal respect. And the second one, of course, was who said this to whom and when. Uh, but we move on to the other questions that we have. And Dr. Gauri Shankar says, Sir, long standing open wound, tissues are visible. Um, how do you decide whether to give a topical antibiotic or a systemic antibiotic? And then which ones are the ones that you use commonly?
Sir, first thing is first is definitely antibiotics. Regarding antibiotics, sir, antibiotics are usually not needed in the care of diabetic foot, the topical nor systemic. But if patient has developed osteomyelitis, how do we check for it clinically? Probe to bone test. In a wound, we can have a probe to check for look for a bone. If you are able to touch bone, and then definitely there is evidence that most likely we're dealing with osteomyelitis. Then patient definitely needs antibiotics for at least 6 weeks. If we have some infected, it's oozing out, it's not clean, visibly pus is there, we need antibiotics, systemic antibiotics mostly. Topically, what we say is usually clean it with a normal saline and dress with a spiral gauze piece. There is no need to apply for topical antibiotics in these cases. If patient has an exposed wound, as you were saying that it's a big wound, it's not healing, probably patient needs some sort of debridement also. And look for osteomyelitis. If patient ulcer is not healing, the most important reason of non-healing big foot ulcer is underlying osteomyelitis. So if we cannot check it on our physical examination, which is sometimes actually misses osteomyelitis, the MRI of foot is a very important test. MRI foot can tell us why the patient is having non-healing ulcer even after giving a good care.
Thank you, Dr. Smith, and I hope that answers Dr. Gauri Shankar's question. Of course, if there is an abscess, uh, drainage will be required. Then incision and drainage is must if there is a fluctuant abscess. And if there is an infected wound, then you have to give aerobic and anaerobic coverage both, and it should be adequate. Do remember that a person with diabetic foot will usually have poorly controlled diabetes, and you may have to use the antibiotic for a longer period of time. But there has to be objective evidence of infection before you give an antibiotic. The objective evidence might be a raised TLC, might be a very high CRP, or it just might be what you see, a visual inspection, and you see or you smell. Even your nose is an objective marker of how infected a wound is, because you can smell the anaerobic infection from far. अनूप शुक्ला जी पूछते हैं इन हिंदी एंड इंग्लिश बोथ, ऐसी कौन सी मलहम लगाएं ताकि तलवा सुरक्षित रहे. So any cream that you would suggest for primary prevention of diabetic foot ulcers? You've already mentioned about footwear, but can you focus on the topical therapy, please, in both
Definitely, sir.
languages?
Any moisturizing cream, sir, for prevention. Avoid cracks. Even coconut oil is good. Just avoid cracks.
तो कोई भी moisturizing cream, anything that you are that is available at the pharmacy or at the grocer's shop, and uh, especially in winter months. And then, Dr. Sunit, moisturizing means that we want to hydrate. Now, too much of hydration. My feet are wet, they are moist. I am too lazy to dry them, or I'm in a hurry and I wear my socks over moist feet. Then I wear my shoes and I go to work. And I'm going to remove my shoes and socks only after 12 hours. What can happen?
Fungal infections is pretty common, and that will lead to, especially in between the toes, and that can go into like non-healing kind of problem. That is one thing. And wearing socks over the wet foot is not good. And I'm not saying apply water. I'm saying apply some sort of like emollients, not water. So it should be well dried, अच्छे से पोंछ के, और अच्छे से एक बार मॉइस्चराइज, कुछ भी मॉइस्चराइजर सिंपल उस पे लगाएं और पहन लीजिए शूज. दैट इज इंपॉर्टेंट, दैट प्रिकॉशन इज टू बी टेकन.
Yeah, so we'll repeat, keep your feet dry, especially the space between the toes. जो पैरों की उंगलियां हैं उनके बीच में खासकर जगह है उसको ड्राई रखना है. And be more cautious, be more vigilant during winter months because that is the time when we are a bit lazy. मोहम्मद ताज जी का क्वेश्चन है कि कान में घंटी बजती है तो इसका तो मोहम्मद भाई टेस्ट करके ही पता चलेगा. हो सकता है कान में सुराख हो सकता है कान में मैल जमी हो या वैक्स जमी हो, तो वो डॉक्टर निकाल देंगे, पर दिखाना जरूर चाहिए. Dr. Gauri Shankar asks other questions as well. One is, we've talked about when to use antibiotics, systemic antibiotics. Uh, when do you do a dressing with ointment and when do you do a simple dressing? But before that, perhaps the question would be, when do you do dressing at all? When would you want to keep a wound open and just leave it open? What kind of season, what kind of lifestyle should the patient be following where we say just keep the wound open and it will heal with
Sir,
glucose
first,
control?
beside glucose control, sir, there is no time when the wound should be kept open. One thing is should be uh, thoroughly cleaned, and what we suggest is like clean with normal saline, straight normal saline. Don't use topical antibiotics, and then clean it. Like sometimes we have an infected like first is there. We use sometimes betadine. I'm saying again this kind of things, but that is usually any topical kind of antibiotics, be it like povidone iodine, or be it like some other type of topical antibiotics. One thing is very important. Like what they say is, please do not put anything in wound which you will not put in your eyes. This is a dictum in the care of diabetic foot. So probably will not put povidone iodine in our eyes. So don't put it. Clean it, dry it, and not dry it, and then with a gauze piece, just do the dressing. Topical antibiotics usually don't have any role. Another thing is, if patient is having like almost healed wound, that can be cleaned with povidone iodine and can be left open. But a oozing wound, big wound, exposed wound should not be left open.
Thank you. And then what about drugs like silostazole? These are femoral bed vasodilators. They dilate the femoral bed. What are their indications?
Sir, silostazole is the management of PADs, not diabetic foot per se. So the claudication distance will increase. That will help in improvement of, like, a patient is not able to walk by 50 meters, maybe he is able to walk may 100 meters or 150 meters or 200 meters without pain. Another very important management in the claudication is like, or this kind of peripheral artery diseases, like ask them to move for at least 1 hour, even if they are feeling pain. Ask them to stop for few minutes when they feel pain, then walk again, but walk again for total 1 hour. This will gradually open the channels, and this will help in increasing this claudication distance. And that is one of the best management in the peripheral artery disease. Medical, मतलब
Treatment.
non-medication wala medicine management. Silostazole has an importance. Patient is not able to walk. Patient is too much distressed. He is not able to walk even from his bed to like his door. So the distance will definitely improve. This is a
Thank you.
rheological agents, so that will improve the permeability of those RBCs through the almost blocked arteries.
Thank you. And thanks from Dr. Anshul Singhai from Chhattisgarh and Dr. Vinayak Sharma, who thank you for the enlightening session. Dr. Anshul Singhai asks both of us if we have used lobeglitazone in type 2 diabetes.
Have not used this, are you?
Yeah, I've also not used Anshul because we have pioglitazone, which has gone through so many trials and tribulations also. So we have very good evidence for pioglitazone. Lobeglitazone does not add any value to the PPR gamma space, none at all, and it is not backed by long-term outcome trials. Dr. Sanjay, I think both Dr. Sunit and I, we thank you for your very kind words about the style of speech and presentation. One question is about nebivolol. Now, we use beta blockers in multiple situations, in heart failure, for example. And for many years, beta blockers were not included as an antihypertensive drug. But now the latest guidelines do specify indications where you can use beta blockers as an antihypertensive drug, which is very nice. It is very welcome. But the specific question from Dr. Singh is nebivolol as compared to other drugs. Is there any benefit as compared to other beta blockers?
In PVDs, usually we say that don't use beta blockers, but yes, in nebivolol, it's again more of a cardioselective, so can be used as compared to non-specific beta blockers.
Right. But peripheral vascular disease, if possible, try to avoid use of beta blockers unless maybe there is a compelling indication like heart failure, like portal hypertension, and then you have to give the beta blocker. What are the safety concerns with the silostazole? Any adverse events that you have encountered?
Slostazole, no. Honestly, I'm not aware of any this kind of, because we start with the low dose and then titrate, and I've not seen any sort of specific symptoms or seen any adversities with slostazole use.
Some patients may present with edema, so you have to counsel them about that beforehand. You might wish to say that, we are trying to push more blood to the feet, so you might experience edema for a short period of time. Don't worry. This will be more common if silostazole is being given along with a calcium channel blocker. Secondly, very, very rarely you might have hypotension, but that's not a major issue. Now, if the BP to start with is 90/60, then I think it would not be a good idea to give silostazole. Dr. Mukesh has a challenging question. He says, "Sir, we avoid pioglitazone in liver impairment if the SGOT-PT levels are more than 3 times." Okay, so can we use it in liver disease, NAFLD, NASH, if the SGOT-PT is around 120 to 130?
Sir, one should avoid. And the things are like we have so many upcoming drugs and so many medications for the treatment of NASH now. So better is like we avoid in case of transaminitis, and there are many other drugs available now.
Which we
So we can use in the management of NASH.
If you are worried in general and the main aim is glycemic control, then insulin would be the safest. So anytime you are afraid, you are worried, just fall back on insulin. You cannot go wrong. Tell the patient also the OTPT is high today. If we work together, uh, we will be able to bring it down. The primary treatment of NAFLD or NASH is weight loss, 3 to 5%. So let's work towards that. We also might want to start a physio-friendly glucose-lowering drug, which will help in weight loss as well. So this is one kind of counseling to give the patient. Second is we have got a cross-sectional value, that is SGOT-PT is high today. We really don't know how it will be tomorrow or day after. It might be an acute illness. And sometimes I tell my patient, it's possible that you've had jaundice or subclinical jaundice in the past, but because you were so strong, because your constitution is good, that's why you didn't feel it. So how will we find out now? Uh, Jaundice or infective hepatitis is a monophasic illness. So we'll check the OTPT again after a week. Now, whether you're checking after a week or after 2 weeks, that will depend upon the clinical situation. But you can explain to the patient, today, the decision we are taking is based on cross-sectional data. The decision that we will take tomorrow will be based on longitudinal data, and that will give us better insight into what is happening in your liver. But do not worry, we are very confident that we'll be able to manage it. So do keep on sharing that optimism with the patient. A second question from Dr. Mukesh is, should we stop pioglitazone before minor surgery like cataract?
No, no.
If patient is stable, yeah, we can continue.
Only
Do
problem
be
with
aware.
this. Mhm. Sir.
Yeah, carry on, sir.
Only problem with these drugs is we are not supposed to use them in retinopathy.
Yeah,
No
proliferative
problem.
retinopathy. And that was exactly what I was going to say. But otherwise, we can continue the drug. Now, this question, I really wonder if Dr. Sunit will or I will be able to answer, but we can always have a video for it. How to do a dressing in diabetic foot?
Dressing is like what we have seen, what you have done is like you just pour in this, clean it, look for some obvious plus points if they need some sort of debridement. Any like if the wound is healthy or not, make it healthy. Try to make it clean by debridement. Then clean it with normal saline and do a wet gauze dressing. And wet gauze dressing is important, and that dressing is to be done daily. That is one simple way. Otherwise, it's not like one shoes is going to fit all. It depends on a type of wound. Uh, what is the situation of patient actually at that point of time? Sometimes we really need the help of surgeons. Sometimes we really need the help of orthopedician for amputation. It actually depend on real situation what we are dealing with at that point of time.
We can talk about the red flag signs, Dr. Gauri Shankar, when we must refer a patient. So let's do it in a very simple kind of manner. Let's ask Dr. Sunit. When you smell a foot, what is the red flag? What would make you want to refer a diabetic foot patient to another center where there is a surgeon, just based upon smell? Again, cross-sectional and longitudinal both.
Fishy smell is like the patient is having anaerobic some infection going on, bad infection going on, and we really need to send the patient for proper debridement and cleaning. What you
You
see on the on just on the surface may not be the real picture. Things may be like too bad inside, so we really need to refer them.
we are giving metronidazole, satronidazole. We are giving adequate anaerobic coverage, and still the smell is worsening. That is a red flag. So S was for smell. S is also for sight. By seeing, by looking at the color of the wound, and we've been watching it for the last few days. We've been doing a dressing. What kind of colors would make us happy? What kind of colors would make us want to refer the patient?
Sir, it's a red, basically a red granulation tissue. So red granulation tissue is definitely a welcome. So if you see yellowish, greenish, creamish discharge, that is suggestive of infection, sir.
And if the black keeps on increasing, then that is a sign of impending gangrene. So it's a good
Great.
idea to refer. Yeah. Because with these, Dr. Gauri Shankar, sometimes the outcome is not good. So it is a good idea to refer in a timely manner. If it is red, you can actually counsel your patient very optimistically. I know that you are afraid, but what this means is that our medicines are working and blood is reaching the wound. So the antibiotics will also reach, the medicines will reach. So S was for sight, S was for smell, S is also for sound. And Dr. Sunit, you alluded to this when you spoke about sounding the patient for osteomyelitis. So what do you do actually? What kind of probing do you do? And what does that tell you about whether you have to refer a patient or not?
Sir, probing is essential part. If we see a big ulcer, we should have a bone probe and look and try to go deep. If you are able to touch bone, if you are touching bone easily, and then this most likely there is a bone involvement and everything has been eroded already by the diabetic ulcer. So we really need to look for a diabetic and go for a simple X-ray. If we can find some findings in that, it's okay. Most likely we're dealing with osteomyelitis. Then patient have to be in care of orthopedician or a surgeon along with our care. So
Yes.
then this becomes a very important sign, sir. Another thing is if we are not able to localize, if we are not able to see anything on X-rays, and we strongly suspect patient is having foul smell, patient is having persistent oozing despite caring, and patient is either or maybe running high-grade fever now. So we suspect osteomyelitis, go for MRI. That will give us answer, definite answer.
Two similar questions from Dr. Yagya Bhushan Sharma and Nitin Narula ji. So, Yagya Bhushan Sharma ji has a question on causes, on etiology. What are the possible causes of numbness of the fingers of the foot and hand in diabetes? And Nitin says, what are the causes and treatment for numbness in the genital area in a 47-year-old gentleman?
So numbness again is a sign of so many things. This can be in a diabetic patients, unless proved otherwise, we can say it's like probably are dealing with diabetic neuropathy. This can be a sign of some nerve entrapment, maybe in a cervical area, maybe in the lumbar area, some areas. It's possible looking at the site, depends on the site where the patient is complaining of. So, if we are thinking that this is probably not nerve entrapment and we are dealing with the diabetic neuropathy, then we really need to look into it. We go for examination and try to find out hot and cold sensations and pain touch sensations, monofilament test that is to be done. And if we are able to if patient is having only sensory symptoms, even then we can find out something on monofilament test. So how do we treat, how do we deal with these kind of problems? Many things. We look for a vitamin B12 level. If our vitamin B12 level is low, then we first we treat vitamin B12 deficiency. Second can be it's a pure diabetic neuropathy. Then we need to use some sort of drugs like gabapentin, pregabalin, or some newer drugs, different, and ALA to have a role. So these kind of drugs can be used for the treatment of neuropathies, or for this kind of tingling sensation, this kind of burning sensations. Same holds true for any these sensations anywhere. In the genital areas, sensations can be because of some fungal infection. Look for it. Examination is important. There can be in case of like melanoprostatitis, patient is not able to tell you. Patient can have a like female can have vaginitis. So that can also lead to this kind of irritation. Can have some sort of like a perineal itching. That also can be because of some infection or maybe some sort of external hemorrhoids. That can also lead to. So everything is not neuropathy, but in diabetic patient per se, we say like in the hand and feet, probably dealing with neuropathy if there is no nerve entrapment. So treat the
Sometimes.
cause.
Hmm. And sometimes our patients are in distress, so there's no harm in offering a comfort food or a comfort beverage. An example would be we give exactly the same treatment that Dr. Suneet has done, and I know that he does this in his OPD. We thank Dr. Lambe also for your kind words. The similarity with Dr. Suneet that all of us share is that we are all patient centric. When we are seeing the patient, it's the patient who is the center of our universe. So we might, for example, say, why don't you take some turmeric milk along with whatever medicine you are giving? Or you might say in winter, cinnamon in your tea or in your milk, or maybe ginger. Now, these are familiar foods, familiar beverages. The patient feels comforted. Now, whether the ALA will work or the gabapentin or the pregabalin, that is a work for researchers to do. But when you add these words of comfort and you also add foods and beverages of comfort, you find that the patient satisfaction goes up and outcomes also improve.
Sir, definitely, yeah. So many psychological aspects to be taken care of. Sometimes patient do have maybe some reason, chronicity, fatigue, everything, treatment fatigue, illness fatigue, some other fatigue, some social problems. They need some solace. That's it. They need something like I should tell them other than medications, writing medications. Yes, that is needed. That's always like helpful. But actually depends, like patient is having a florid problem and we are asking for a haldi wala doodh, then it's not going to work.
Not alone. Yes, it should be an adjuvant, not alone. But to Dr. Sanjay Marathe and to Dr. M.A. Lambe, I would like to say that actually Dr. Suneet takes care of me. He takes care of my blood pressure. He's trying to take care of my weight. And also, whenever I'm ill, I have a fever or something, then he's my go-to person. So he takes care of me. So he's the one who is explaining these things to me all the time.
So sir is
One
always taking
question
care of me, brother.
One question I'll take. We have many more questions. Dr. Mukesh says, in a 50-year-old patient with 100 kg weight, TSH is 7 to 8. How do we differentiate between obesity-induced high TSH or actually Hashimoto's thyroiditis? So the first test you've already done, sir. You did an anti-TPO and that is negative. So it goes in favor of obesity. The second is we can try a TSH ultra-sensitive. So order that. And if that is lower, the chances of it being related to obesity are more. The third is ask the patient to do a trial. Let's try to reduce weight, maybe for a month. Non pharmacological means, pharmacological means. Let's see what happens. And within a month or 6 weeks at the most, you will find that the TSH will come down, even if the weight comes down by only 2 or 3 kg. So patient will come and say that, I spent so much effort. I went to the gym. I almost starved, doctor, because of you, or I took such and such medication. My weight has come down by only 3 kg. That's 3% on 100. But you will find that the TSH comes down. So the best way is to just try an obesity management for 6 weeks and do a TSH ultrasensitive after 4 to 6 weeks. But with this picture that you're giving, it would be probably due to obesity. Another point is, had this patient been 25 years old, wanting to plan a family with a history of infertility, subfertility, recurrent pregnancy loss, then we would treat, then we would not wait and watch. Here, this patient is 50 years old, whether a gentleman or a lady. So we can say, see, the prime years of your hormonal health are over, and now we just have to maintain. So it actually doesn't matter too much if your TSH is high. We will take good care of you. What harm can a high TSH do? It might cause dyslipidemia, so we'll do a lipid profile. We can treat that if required. The weight we are already working on. It might cause elevation in liver enzymes, SGOTPT, so we will do that as well. And we will be mindful of your comprehensive health. So that is the best way to handle such a patient. Don't jump to starting thyroxine. We welcome Dr. Gebre Mikhail from Ethiopia, I think. So Dr. Armias Gebre Mikhail shares two challenges with us. The first is, and Dr. Armias, Dr. Sunit is a perfect person to answer. This is his specialty. Dr. Armias has a patient with diabetic foot that is oozing pus, also has diabetic kidney disease. Culture has revealed Klebsiella, which is sensitive only for meropenem. So, Dr. Sunit, two questions for you. What dose of meropenem? Diabetic kidney disease is there. What should we keep in mind? How vigilant should we be? How long should we give the antibiotics? That's the first question. Second is, supposing meropenem is not available and we are faced with a situation like this, resistance to all antibiotics, or one or two antibiotics are sensitive, but they are not available or they are not affordable. Then what do we do? What is the best possible that we can do?
So both type of scenarios are very common these days. One thing is meropenem. Meropenem sensitivity, Klebsiella sensitive only to meropenem, Klebsiella sensitive only to imipenem, or maybe any type of carbapenem, and or only sensitive to this colistin kind of medication. It's pretty common now. So what we do is like in a renal modified dose. First is in adult patient we usually say give a full dose 1 gram loading, then modify your dose according to RFTs. So according to GFR, we modify dose and then give them. How long we should give? It actually depends on what kind of wound we are having. We really need to rule out if we are suspecting if it's foul smelling is really bad. Is there any underlying osteomyelitis or not? If there is no osteomyelitis, then 10 to 14 days of antibiotic is at least what is needed in this kind of wound. So 10 to 14 days of meropenem is needed for treatment of this kind of wound, sir. We have studies from our CMC fellow even. They say even a short-term treatment of 7 days is sometimes suffice. But it depends. Till now, what we are saying is at least 10 to 14 days of antibiotics in a non-osteomyelitic limb and diabetic foot ulcer. So, second question, what sir has asked, if the patient is showing XDR, like it's resistant to all drugs, there is no possible drug, then this is always Tiran Tukka, sir. So then what we do is what we are getting in a community. This is not only diabetic foot. This is true with the UTI, urinary tract infection. This is true with the sepsis of unidentified like focus. We are getting something in the blood only, and then we are getting patients who are like totally resistant to everything, including meropenem, colistin, polymyxin, every damn drug, tigecycline, everything. These are resistant, pan drug resistant. But how do we deal with it these days? Like one thing is like try with something which society is not using. Ceftazidime avibactam, what we are using these days in these cases. Ceftazidime avibactam has is proving good. Using alone a single antibiotic is probably not good. Use any of the drugs which you are comfortable with, maybe meropenem, maybe colistin, maybe tigecycline along with. Use two drugs and try to see for the clinical response. Because something is to be done, patient is dying, and if we see that no drug is working, so we won't give any drug. It's not a solution. Yes.
Thanks. Dr. Shashi Khare says, can we apply steroid cream on cracked heels?
No, sir. No.
Uh,
Emollient is
it will
needed.
be, yeah, it will be risky. It is oil or moisturizer that is required, and steroids will actually end up thinning the skin. So we will end up with with a worse situation than we began with. Dr. Bharat Praveen has a very challenging question. Though you've spoken about this in different ways, but perhaps one, two, three, four, five, you can list the answers. How can we speed up the healing of a diabetic foot ulcer or diabetic foot infection? So, Dr. Bharat, let's try to classify this. First is metabolic control. Second would be maybe orthotic or footwear or lifestyle management.
Okay.
And third would be the ulcer management, both antibiotic and non-antibiotic. So one by one, Dr. Sunit, please.
So rightly said, sir. First is first. We need to look into the glucose level control. That is to be controlled aggressively in these patients. Second is like control of concomitant illness. Patient is having either having peripheral artery disease, then look for the management of PADs also. Try to look for any reason which can actually delay the healing, be it a routine load bearing on that area. So we need to offload that area. Any swelling, if patient is having any swelling causing medicine, maybe CCBC is taking and causing of like limb edema, we need to replace that with something else. Any underlying heart failure, any underlying CKDs, if leading to edema, then we need to take care of that edema. So try to find out a reason for which we can think can delay healing. Try to remove that. Patient is having big ulcer, then vacuum therapy. This says vacuum therapy can actually increase the chances of healing and can decrease the duration needed, but it's costly. Before going for any fancy thing, most important thing is again metabolic control, offloading. That is also very important. So that is to be done. General care. Patient really need to understand the importance of care, and they really need to get the some dressing done. That is to be done regularly. No use of any topical oils or something like for some different type of treatment. That is not to be done, and which is actually surprisingly common. They apply anything on the wound, and then patient goes into non-healing kind of situation.
Thank you. And Dr. Archana Jain says, sir, what is the role of pus culture in the management of diabetic foot? Specific question is, at what time would you want to send a culture? On day one of the patient visiting you, or maybe a few days after you find that the initial empirical therapy has not worked?
No, sir. Best is like if possible, clean it first, send a culture on the day one, and then if patient is not responding, definitely that becomes an indication of sending a culture again. But day one culture is important, and that should be sent. And if we are not able to send, if we see that a patient is so exposed when everything is contaminated, then like patient has never taken antibiotics and we don't have resources, or patient is not able to afford these kind of things, not able to follow up with you, maybe he gonna get a dressing done at a local place, then we can deal without, even without culture. Because in most of the cases microbial, so growth is usually polymicrobial.
Vasodilators like silostazole, we've already discussed. Dr. Armia says, what is the best empirical antibiotic coverage? So maybe we can make this simpler. Dr. Sunit, in your ICU, in your indoor ward, and in your OPD, supposing there's a diabetic foot patient, what are the antibiotics that you use most commonly?
Sir, if there is like oozing pus and I need to use antibiotics, in all cases, antibiotics is usually not needed. But in some cases, we have decided that we need antibiotics. Then antibiotics in OPD basis is mostly amoxiclav. We start with amoxiclav, like or sometimes cefuroxime. Cefuroxime works well, and along with clindamycin, along sometimes with metrozel. Metronidazole is needed. And these are the empirical antibiotics on OPD basis. And what we do in IPD is if wound is really bad, then piperacillin is a victim, along with metronidazole
Hmm.
or along with Clinda. This is what we use practically. And like we patient is really sick and is in sepsis, and procalcitonin very high, and all sepsis marker are very high, having need of vasopressors or some ventilators, definitely carbapenems to begin with.
Carbon. Tazobactam has anaerobic coverage as well, and sometimes you have to add metronidazole, but most of the time you can manage without that as well. So it's actually, I'm sure Dr. Ermias, I don't know the age, but by default, all the older physicians, we've become so used to writing metronidazole in India that we forget that the newer drugs do have anaerobic coverage as well, like
Yes.
tazobactam, for example. Dr. Ermias says, your opinion on long-term use of clindamycin for diabetic foot.
So why long term issue is like, if we do we really need antibiotic for long term in diabetic foot? If patient is having osteomyelitis, definitely 4 to 6 weeks. But in general, if patient wound is not healing and wound is healthy granulation tissue, and we are waiting to deal this with antibiotics, is probably not like the right thing. What I feel is what guideline says rather. So what we do is use antibiotics for shorter duration. If patient is not having osteomyelitis, try to do debridement, clean it, and daily dressing, and then manage with dressing and offloading and general care. No long-term antibiotics. As I said.
Another drug, Dr. Gabriel Michel, that you may wish to consider is linezolid, which is bacteriostatic actually, but it has good penetration into the bone. So depends upon why we are using and how long we wish to use, but linezolid, clindamycin, as long as is required. If you have a label of osteomyelitis, then certainly 1.5 months or so is needed. Dr. Shigufta Yasmin says, sir, you spoke about vacuum therapy, but what about hyperbaric oxygen therapy? Does this work, and what is your
No,
experience?
it doesn't work, sir. It's more of a like fancy thing, and so many studies they're saying that it's not working. Hyperbaric
I
oxygen therapy practically doesn't have any role in the management of diabetic foot.
few more questions, and salam to Dr. Altaf Chima, who has joined in from Lahore, Pakistan. Warm welcome, Altaf Bhai, and
Sir.
best wishes for having conducted the election safely. And we hope that good outcome, peace, and prosperity prevails all across the world. Now, lots of more questions on diabetes, Dr. Suneet, if you allow. Uh, some need just short answers. Dr. Lambe says, which anti-diabetic drug class, and can you just list the drugs in this, which cause itching in the female genital area?
Sir, SELT2 inhibitors, they can cause this kind of problem. Sometimes itching is because of DPP4 inhibitors also. So it is a generalized pruritus, not in genital. Genital areas, itching is mostly because of SELDR. Reason being is like they causes more sugar to get excreted from the urine, and that leads to chances of increased fungal infection over there.
In postmenopausal women, there may be a chemical irritation because of the
Hmm.
SGLT2 inhibitor. It's not that the SGLT2 inhibitor has caused a fungal infection, it's just the chemical irritation. And in such patients, estrogen cream is helpful. Dr. Shugupta says, how long can we prescribe gabapentin or pregabalin in neuropathy, in painful neuropathy? Can it be given indefinitely?
Can be given indefinitely, sir, as long as your patient is able to tolerate.
Tolerate. So we start, Dr. Shigufta, in most patients, we are able to taper off or stop also after a few weeks, a few months. But some people do keep on taking for years altogether. These are my patients, especially those with pancreatic diabetes, who have had very poor control in the past. So they kind of become dependent on these drugs. Try to taper off every 1.5 months or so and see what happens. Dr. Bishwajit Heldar says, sir, your experience with imeglamin, please.
So this question is for you.
Imeglamin, Dr. Biswajit, I do use. It is a dual acting drug. It reduces insulin resistance. It also increases insulin secretion, especially the first phase secretion. So when do we use it? When 2 or 3 drugs are not acting, or when the patient is on insulin and the insulin requirement is going very high, and we need to give something. Another indication where I use it is people who complain of increased appetite. So the patient is actually very faithful, trying his or her best, but says, "Sir, what can I do? I just can't stop eating the idlis, or I can't stop eating the pranthas." Now, if there is one country in the world where food is tasty, that is India, but a second country is Ethiopia, and a third country, Lahore food, anybody would die for. So now it's not our fault that Ethiopian or Pakistani or Indian food is tasty. So patients are not able to resist sometimes. Then again, I add imeglamin because it actually does reduce appetite. A third indication is patients with the kidney disease, chronic kidney disease, maybe an EGFR of 30 or so. Patient is not willing to take insulin. Then two drugs that you can use very safely are linagliptin 5 milligram OD and imeglamin 500 milligram OD. So these are some indications where I use it, but not as a monotherapy. Dr. Anshul, thanks you, Dr. Suneet, for a very insightful discussion. एंड
Thank you, sir.
ऑल्सो थैंक्स टू यू फ्रॉम अनूप शुक्ला जी जो कह रहे हैं कि धन्यवाद आपने बहुत सहयोग दिया है एंड वी विश यू ऑल द बेस्ट अनूप जी सेहत के लिए local gabapentin I know that it is available. Dr. Suneet, have you used that for diabetic painful neuropathy?
No, sir, I have not used it actually. It's available, I know, but not used it.
I've also not used. FDA has approved, Anshul, it has approved capsaicin cream. It is approved by FDA, 8% capsaicin cream. But and this is mentioned by ADA as well in their guidelines. But in India, it is 8% is not available. It is a lower percentage, and even that is will suffice in some patients. It will have a counter irritant effect. So if your patient is not able to tolerate oral drugs or need something extra, you can try capsaicin. That will be supported by the guidelines. And Yagyabhushan ji कहते हैं, sir is 70 years young and sir follows very good lifestyle. He never falls sick. Numbness in winters only in winter. Numbness in fingers only in winter. ये वाकई होता है शर्मा सर जी. Will vitamin B12 help me?
Sure, sir. There can be so many reasons. Vitamin B12 deficiency is one thing. Another is cold induced. Maybe you're more sensitive to cold. That is also one possibility. Second is during winters, you may be having underlying some cervical neuropathies, cervical radiculopathy, underlying cervical radiculopathy, which get worsened in winter because of the postures, because of so many clothes on your shoulder at that point of time. That can also lead to numbness here. And so some sort of stretching in the morning and some sort of massage, some sort of hot fomentation over the shoulders and the cervical area can help. And definitely vitamin B12 deficiency is to be ruled out and that is to be taken care of. If still you have this kind of symptoms, a short therapy of gabapentin or pregabalin will be helpful, sir.
Thank you, Dr. Suneet. This question from Dr. Haldar, sir, please allow us to take it later because the question is what medicines do we give for erectile dysfunction? This would be a complete topic. I think we have discussed sexual dysfunction in men in the past, but we will do it again anytime next year during FDC Diabetes Essentials. One question from Dr. Shigufta. Should all diabetic foot patients be subjected to an arterial Doppler? If the patient
Precisely.
cannot afford a Doppler, what is the simple test? What index can you calculate? How do you do it?
Sir, not all patients should undergo arterial Doppler for sure. This is like all diabetic patients should undergo coronary angiography. It's not like that. So it's the same and the same thing because they are prone to coronary artery disease. That doesn't mean they need a coronary angiography. Same is like they are prone to peripheral artery disease. That doesn't mean they need arterial Doppler in all. If you can do some clinical symptoms, history wise, if you find there is a claudication, if you suspect something, if you see there is a bluish discoloration of tips of toes or fingers, if we find there is a problem with ankle brachial index, if you find there is some problem with palpation or feeling of posterior tibial artery on clinical examination, for non-healing diabetic foot ulcer, definitely we need to go for a doctor test.
ABI, how do we measure that? Simple tips and tricks.
Sir, ABI
Ankle
ideally should be
brachial
measured.
index. Yeah.
Ankle brachial index is to be measured with again with the Doppler. We see the systolic BP in the ankle and the brachial area, and this is the way we collect ankle or brachial. So, but clinically, what we can do is practically it's not that e like accurate, but still we can do with the systolic BP that is to be seen, and with the even finger, and then same in the ankle, then followed by in the brachial area, and then we can find out the ankle brachial index. Simple
So you
manometer.
just need sensitive fingers and you need a sphygmomanometer, and you can actually do that. That will help you.
Yes.
Dr. Armias is 44 years young from Ethiopia and who has done his endocrinology from St. John's, Bangalore in India.
Right.
So thanks, Armias, for joining us. Armias, if you can share your WhatsApp number with us on the chat box, we will include you in a global endocrinology group and also put you in touch with EADSG, which is East Africa Diabetes Study Group, and they will be happy to be friends with you. With this, I'd like to thank everyone. One last question I'll take. This is about Mehndi. Now, Dr. Sunit, while I answer the question, another question is a nice Bollywood song on Mehndi or maybe a Punjabi song if you're in a good mood. So, Dr. Shrigupta says Mehndi and neuropathy. So, plus side and minus side both. Mehndi is a cooling agent. And actually, we encourage our patients if they have painful neuropathy or if they have a feeling of heat over the hands and feet, they just apply Mehndi once a week or so. It gives a very good, cooling sensation. The patient feels happy, the family also feels happy. And you can apply Mehndi not only on the sole of the foot but also on the dorsum up till the ankle. So I've seen that it helps. The English word Armias for Mehndi is now I need to think. It'll just come in a few seconds. Uh, and I know that this is used in Ethiopia and across North Africa as well. We'll just get it for you in a minute. Dr. Sunit, if you can find that for us, the English word for Mehndi.
I'll try that because I don't remember as of now, but
Yeah, we
well,
can just Google. Now, the negative side, Shagufta, is that let us say the patient has an ulcer and you've applied Mehndi, you may not be able to see it. Patient got bleeding at night. Maybe there was a rat bite. Then again, it may not be obvious because of the Mehndi. So just be aware of that, that the color will change. But otherwise, Mehndi is something that is culturally appropriate and culturally accepted. It may cause difficulty in early diagnosis of bleeding or ulcer, but you should just be aware of that. If the treating doctor is aware, then it's fine.
sir, henna,
Henna,
henna.
Henna. Yes, thanks. So henna is something that is used for beautification, and here in northern India, Armias, we use it as an alternate to capsaicin. It's not counter irritant. It's just a relaxing and cooling kind of an agent. Thanks to Dr. Aditya from Chennai. Thanks for being with us, Aditya, and thank you, Shegufta, for henna. Yes, sir. Thanks, thanks for helping us out, and thanks everybody for being with us. With this, I'd like to thank Dr. Sunit. Your shows are always a hit, and we always go beyond 1 hour. So now it is 10:18 p.m.
Thank you, sir. Yeah,
And,
all your fan following, sir, including
and
me.
the question about uh, being a dil ka yaar or being a jhanjar of the pair, being an anklet on the foot, that we will leave until next time. But Ankur and Mr. Kunal is with us. Mr. Kunal leads FDC team now, and Ankur is looking after FDC as well as diabetes essentials. Ankur, how was your day and did you learn anything new today?
Yes, that means Sunil sir is like a rock star for Diabetes Essential. Whenever Sunil sir comes, our session goes for above 1 hour always, and we get the maximum number of viewership. So thank you, Sunil sir and Sanjay sir for giving us such a thought provoking ideas and for thought provoking talks on the today's topic. I would like to thank all the doctors to take part and have the patience of being with us for 1 hour and 20 minutes. So thank you so much. Next week we will meet once again with new energy and new topic. So Jai Hind and good night. Thank you so much.
Thank you.
Jai Hind.
Thank you, sir.